Hello and welcome everyone. I am Dr. Philip Chang. I am the current SRS Foundation president, and I would like to extend my gratitude for everyone attending this very timely discussion on the future of OSA treatment. I think it's going to be very exciting. Next slide, please. I'd like to also extend a special thank you to our generous corporate partners for supporting this webinar. We have Lilly, Inspire, ResMed, Knox Medical, Fisher and Paykel Healthcare, Sleep Image, Natus, and Wesper. So we couldn't be doing this without them. And now I'd like to thank our distinguished thought experts for their time today, and of course, introduce the wonderful Dr. Atul Malhotra, who is chairing the discussion. Atul, it's all you.
Great, thank you very much. I think that slide's a bit out of date. I'm actually the Vice Chair of Medicine and Research Chief for Pulmonary Critical Care and Sleep. I'll give my disclosures as well. So vast majority of my funding comes from the NIH. I do consult for Eli Lilly, Zoll, LivaNova, Pell Mansfield, and Wesper. And I'll have Rena introduce herself as well, particularly given her conflicts. She's the new Chief of Pulmonary at Washington, Seattle.
Hi, thanks so much. It's a pleasure to be here. I'm Rena Mera. I'm the division head for pulmonary critical care and sleep medicine at the University of Washington. In terms of my disclosures, I have consulted for Apnimed, Mineralis, um, and, uh, and yeah, I think those are kind of the major ones.
Great, thank you. Anne-Marie, go ahead, please.
Hi, my name is Anne-Marie Morris. I am the Director of Child Neurology and Pediatric Sleep Medicine at Geisinger in Central Pennsylvania, also the Program Director of our Child Neurology Residency Program. In regards to conflicts for myself, I do work with a variety of companies, including Alkermes, Axsome, Apnimed, Takeda, Jazz, Harmony, Avadel, as well as one more, UCB Pharmaceuticals. But the majority of these should not be of relevance to today's conversation.
Great, thanks very much. And then Naomi, go ahead, please.
Yeah, hi, everyone. My name's Naomi Shah. I'm at the Icahn School of Medicine at Mount Sinai in New York City. I'm a pulmonary critical care sleep medicine trained physician scientist. My leadership roles are Vice Chair of Medicine for Faculty Affairs, and I'm an Associate Dean for Faculty Career Advancement for the School of Medicine. My conflicts are Apnimed, Mineralis, and Zoll, and none of them are relevant for today's discussion.
Great. How did the Yankees do against the Red Sox yesterday?
We're still ahead last time I checked and probably have a better shot at the wild card.
All right, all right. So we will cover some learning objectives today. The title is about the future of sleep apnea treatment, but we'll talk about management as well. So the learning objectives here are to understand sleep apnea epidemiology and current future diagnostic approaches. We'll review recent data regarding CPAP from meta-analyses and clinical trials, data on hypoglossal nerve stimulation, surmount OSA and Mariposa studies we'll talk more about. We'll consider future directions in sleep apnea therapy. So the first line treatment for sleep apnea remains CPAP, but there's increasing interest in pharmacotherapy and other procedures and devices for sleep apnea. So let's explore the existing data on CPAP and the use of medications for sleep apnea as either second line or adjunctive therapies. And we'll further review other advances in sleep apnea therapeutics, as well as management of diagnostic and serial testing. So I deliberately didn't want today to be a PowerPoint, so we're going to just have a discussion here. And I think the first point we wanted to cover is about sort of sleep apnea epidemiology. And we've had some papers on this ourselves, so not to be self-serving, but I'll just summarize a little bit. So 2019, Adam Benjafield and I led an effort with MedX Cloud, which is an academic industry partnership. An estimate about 1 billion people worldwide with obstructive sleep apnea. And then a few weeks ago in the Lancet Respiratory, we had a projection out to 2050, looking at the future prevalence of sleep apnea. And even with GLP-1 receptor agonists and all this, the numbers are increasing, not decreasing, particularly in women. So the increase in prevalence is predicted in the United States to happen primarily in women more than men. And so the numbers are quite staggering. in terms of growth in sleep apnea in the numbers. Maybe I'll ask Anne Marie because she does a lot with pediatrics as well. What are our best estimates these days about sort of sleep apnea prevalence in kids?
So I think when you're looking at pediatrics, we still quote that it's going to be somewhere between 3 to 5%. However, we do recognize that those numbers are also evolving. So similarly, in the adult population where we do see obesity as a major driver to the development of obstructive sleep apnea, we now are starting to see that similar parallel in pediatrics. So when you look at CDC statistics, we generally are estimating that about 75% of US adults are going to be overweight to obese, where we're now seeing up to 50% of children achieving those same statistics. So typically, we used to say that in the prepubescent population, it was adenoids and tonsils, and that was mainly what was the main driver. We now are unfortunately seeing obesity being a main driver of that as well, where it's not uncommon to see a 5 or 6-year-old being close to 100 pounds, and therefore definitely contributing to compromised airways. So I also believe that another factor that likely is contributing to this epidemiologic change is the fact that there's increased awareness. Although there still is a paucity of education that should be delivered on sleep and pediatrics. There is mainly one American Academy of Pediatrics stance, and that's if you see large tonsils and adenoids, ask about snoring. And so unfortunately, there is a bias in pediatrics that if there's a sleep problem, they're only thinking of obstructive sleep apnea for the most part. However, it does at least give a call to action to start really screening and creating access for these children.
Okay, great. Thank you. And welcome, everybody, by the way. I should have said that at the beginning. And thanks to SRS and Christine Davis for organizing everything and Phil for the intro. I'd like to ask Rena and Naomi, they've both done a lot in the area of heart disease. It's a bit overwhelming to think about trying to treat 1 billion people and many more at risk worldwide. And so patients with heart disease may be particularly at risk. And so, Rena, can you give us your thoughts in terms of the prevalence figures when you're considering the subset of individuals with heart disease or risk of heart disease, and how do we get our arms around the numbers there?
Yeah, I think this is a really important area and one that's been studied now for a while. Yeah, it's the prevalence is quite high, and I think estimates range 30 to 50% depending upon the specific cardiovascular outcome you're considering, which is extraordinary if you think about it. With the burden of disease of sleep apnea affecting that degree of individuals and how to best wrap our arms around that in terms of effectively diagnosing in a population that perhaps doesn't present in terms of sleepiness and so forth as you would expect, and then how risk stratification even within that, because there's such a high percentage. Are there certain subsets that we should really be focusing on that are in particular more vulnerable to adverse cardiovascular outcomes? And we do know a bit about, predictors, and in particular for atrial fibrillation. And so, yeah, so I think there's a lot to consider there.
Okay, yeah, we'll come back to that idea of sleep apnea heterogeneity for sure. Naomi, I might ask you, I know you've done some work with artificial intelligence trying to use the signals in a way that's more meaningful. Can you give us a little bit of background on that and give us some, for those of us who are not aficionados of AI, can you tell us a little bit about what you're up to?
Yeah, and thank you so much for having me here and for the opportunity to contribute. First of all, it's a team effort. So I work with a team of scientists who are AI, machine learning, and sleep medicine, both from a clinical and a research perspective. So I never want to claim to take full credit. But basically, we just received a grant 2 weeks ago from the NHLBI, where we're applying artificial intelligence tools really designed to look at all of the signals that we get from a sleep study, right? So, I would say think of it as a very careful reader that reviews sort of the whole story at once, right? So you're looking at the whole book, all chapters at once, and you actually pay attention. So these are attention models that are paying attention to key metrics in that narrative. So, maybe there's some noise, but maybe we miss some of the key signals. And I think one of the ones that we've been discussing a lot is sort of recurring drops in oxygen saturation, to the degree somebody has hypoxemia, how long it lasts, and things like that. So our AI-based transformer model was developed in epidemiological data sets, and we're now fine fine-tuning it in some of the real-world polysomnograms, both home studies and full polysomnograms attended PSGs. And the idea here is that we would have a tool where you take a sleep study, you essentially feed it into this black box AI model that we will validate for heart outcomes, like cardiovascular outcomes. So it would basically serve as a standalone, potentially the equivalent would be a stress test. So you go into the, cath sort of stress lab and not cath yet, but you're essentially looking to see what in that study will predict outcomes. We're trying to do that with an overnight sleep study. So I'll stop there. Happy to elaborate later.
Okay. Yeah, I should disclose, by the way, I have a little startup that's related to sepsis and predictive analytics. It's not directly related to what we're talking about, but I should disclose that. I'd like to talk about two things specifically around diagnostics. One is about wearables. And lots of patients come in with Fitbits of various kinds and give information. I'll ask all three of you, how do you use those things clinically? And then I'll ask about multi-night testing as well. But let's start with wearables. What are you guys doing with that? First of all, do you think wearables are there yet as a diagnostic, or they're just helpful for patient tracking, or for how do you use those?
I think, it's kind of on a case by case basis. I mean, I think some patients really have embraced the technology. In particular, I think patients who are engineers really tend to love data. And then, sometimes it attracts the phenotype of person that really gets hyper focused on the data as well, and it can, kind of work against us a little bit. But I think, I listen to the patient if they, bring the data in, and we, try my best to kind of understand, but recognizing that a lot of the time, these devices have not been validated, and it's really hard to, decipher what is important versus not. So it can be a nice starting point, though, to open up the conversation, see, how the data may intersect with the symptoms of the patient, and kind of a launch pad to the discussion of diagnostics and management.
Okay, great. Let's talk a little bit about multi-night testing as well. So there was a paper in Chest by Danny Eckert and his crew, a former trainee, trying to use a single night test to predict hypertension, and it wasn't very good. Well, they did multi-nights over 30 nights. They could predict hypertension really quite well. And it leads to this sort of concept that a single night test tells you about a single night, but not about the whole experience the patient's having. And now with people increasing body weight or decreasing body weight, a lot of them are moving targets over time. So maybe Naomi, do you want to touch on that about sort of multi-night testing and the role of that?
Yeah, I think this is a really common question we get as clinicians. Patients always say, well, one night, one night. And of course, we all know one night is not a good reflection of how we feel. So I slept terribly last night because the Giants played so terribly. So if you did a study, it would probably not be my best night. And so I think you're hitting on a really important point. And I would almost challenge that instead of multi-night, I would say, why not do continuous testing, right? And so my sleep patterns evolve as I am, aging. And a study that I did 5 years ago may or may not reflect what my sleep is like now, and also what my metrics may look like. So I would say, given that we're in 2025, we have the ability to have wearables and home sleep testing. We should be thinking about how do we, have almost like an on-demand patient level interaction that would continuously inform their sleep metric, but also have some ability to predict and have some trajectory analyses, right? And so, yeah, multi-night testing, absolutely, we should be doing that. And a one-night test is really not that great. With that said, given the number of patients we currently have that are in the pipeline or waiting for diagnosis, it's better than nothing. So I think the home sleep testing, especially the disposable testing that came with COVID, has really transitioned my practice and has made it so much easier on patients, where they don't need to go pick up devices. They don't need to drop them off. They're simply mailed, they do the test, and they're disposable. I mean, that's really, I see the happiness on their faces when I tell them that you could just do it when you go to bed and then just throw it out. So
Are your AI algorithms integrating multiple nights like that, or is it focused on a single night, or how does that work?
These are usually single nights so far. Yeah, that's a great question.
So, Anne Marie, I know you've done some really nice work on sort of the patient journey. And
Hmm.
the diagnostic test is part of it, and then multi-night testing would be part of the journey. And I know you had a book on it and stuff as well. Can you just give us a couple sentences about what you're thinking there in terms of the journey and patient-centered care?
Sure. So when I'm listening to this, one of the things I would say is that sometimes in sleep medicine, we become a little bit egocentric of thinking about that we're driving something that is so novel. But the reality is when we're looking at other parts of whether neurology or other fields, we don't stop at one test. If I have someone who comes in and their story is very concerning for seizure, I don't just do a routine EEG and go, doesn't show seizure. Many times we are going to progress and we're going to do long-term monitoring EEG, ambulatory EEG. If I have someone who has a cryptogenic stroke and I'm going, you might have a paroxysmal AFib, I'm not going to say I got an EKG and that's it. No, I'm going to do a loop recorder or something else that is going to give me more data. And in fact, demonstrating that you're going to capture more of those individuals if you record for 28 days. So when you think about the patient journey, exactly what Naomi has already said is that an individual is going to change over time. And we've already recognized that your susceptibility to different types of disorders over time are also going to occur. What else occurs is that you're going to have accumulating disease. When I think about what the role of sleep and circadian science is, it's not just to diagnose sleep and circadian disorders. It is to utilize it as a tool to better diagnose, prognose, and therapeutically intervene on other individuals. So think about a person who's living with something like demyelinating disease. Having multi-night or having the ability to reach for that the same way I reach for an MRI is not going to just give me structural changes, it's going to give me physiologic changes, which may be more meaningful and may allow for me to tailor a therapy much more accurately than what our current modalities are. So being able to actually have this type of information and reach is going to make a huge difference.
Okay. And when you were talking earlier offline about the patient journey from the standpoint of patient-centered care and patient perspectives, can you just touch on that a little bit as well?
Sure. So I think that it's really important to recognize that the current care models are set up for failure, failure for the clinician as well as for the patient. They're currently set up to be episodic transactions of care that do not represent the longitudinal continuous experience that someone is having, which is also introducing the ability to miss a lot of interventions. When you look at even the current models where we're thinking about how we're going to change reimbursement, we continue to fail by utilizing things like value-based care, where they're really only fiscally derived motivations, not something that actually is representing patient desired outcomes. And so it really is important for us to start thinking about what we're doing in sleep medicine to not only reach into the sleep disorders we're treating, but to reach outwards to be able to use a 24-hour approach to any discipline and really demonstrate that this is a continuous model that we need to really redesign.
Great, thank you. So Rena, I was a division chief at some point, and so I know you guys worry about money, and so I'm sure that comes up in your conversations at some point. So can you talk a little bit about in-lab testing versus home testing and multi-night testing and all that, and give us a little bit with a financial perspective as well, not just the science, but the fiscal reality of this.
Oh yeah. Well, first of all, I want to build on the what's been said by Naomi and Anne Marie. And as they're talking, um, this kind of longitudinal trajectory of the patient and being able to collect data that really gives us better insight into the biology. And as they're talking too, I'm thinking, there's so many other socio-cultural behavioral factors, and then I'm thinking about the exposome as well in terms of taking that into consideration, which is so uniquely different from one person to another. So anyway, I just wanted to that was kind of percolating on my mind as they were talking. No, it's a good question. Home sleep apnea testing, disposable testing, as Dr. Shaw was mentioning, really is changing the way we're approaching things, and we need to change because there's just so much burden of disease out there, and we need to be able to capture it and intervene appropriately for our patients. So home sleep apnea testing has really transformed the way that we're approaching things, and for the better. I think it was, we all remember the time where there was some resistance to going that direction, and perhaps some of it might have been financially motivated. However,
Okay.
I think it's actually done. So it's opened up, the doors and our ability to capture the diagnosis and recognizing there's still a role for in-lab polysomnography. Maybe some people would disagree with that, but I think, for those with really underlying complex cardiopulmonary physiology, neurologic physiology, that we would want to better understand the interactions of sleep and understand those complexities that the in-lab testing would really allow us to do. And in terms of a fiscal model, I mean, I think, just again, the diagnosis, using these different approaches and stratifying, risk stratifying, and using that to help inform which direction to go, I think is still, going to be a viable route to go.
Okay. And Henry touched on this, but maybe others want to comment about as healthcare moves from sort of volume-based purchasing, that is quantity of care, to value-based purchasing, that is quality of care. Does that sort of help to justify getting cheaper serial diagnostics rather than just an expensive baseline test? Or how do you guys think about that?
So what I've seen so far of value-based algorithms is that they very much are biased algorithms that don't take into consideration of even things like gender differences. For instance, when I've looked at value-based pathways for individuals with nuanced atrial fibrillation, they're doing a stop bang, which is mainly going to be geared towards men who may have obstructive sleep apnea and may gravely miss someone who looks like me, who's postmenopausal, who may also have obstructive sleep apnea, but will never be positive on a stop bang. And so with that stated, I think that the algorithms are waiting for the literature to catch up in order for it to be actually representative. What it does also miss is it misses the fact that there's no one walking around living with one disorder alone. If you have atrial fibrillation, you may have other medical disorders that are going to modify what is the course that you should be taking. And instead, what it's doing is it actually is creating and inducing barriers to care that are creating a greater degree of difficulty for individuals to be able to access specialists and be able to get the timely care that is necessary. So although they're being developed and illustrated as though that they're going to be something that is going to be life-changing and cost-saving, I actually think it's going to see a potential opposite effect because of the fact that there is much data that is missing to be able to personalize what the response should be for the individual who's in front of you.
Okay, perfect. And Sabrina, I think you know a little bit about AFib as the sort of world's expert in sleep apnea and AFib. Do you want to talk a little bit about diagnostics in that setting? Are there unique considerations in terms of screening tests or priorities?
Yeah, I mean, as Dr. Morse said, I think, the way, certain individuals and certain groups of individuals, our standard ways of screening may not be effective. And there have been a couple of questionnaires developed, one by our group, NABS, and then another one as well, which have been, shown to be perhaps a little bit more effective in being able to screen for obstructive sleep apnea in the atrial fibrillation population. There's a study that we did where we compared those with paroxysmal atrial fibrillation compared to those without, and then tried to develop and validate a screening approach. Yeah, so I think that, and then, going down the pathway of then, diagnostics. And I don't know that we really have, clear evidence in terms of whether home sleep apnea testing versus in-lab testing, and which kind of approach is perhaps works best. We know that there are some shared risk factor profiles between atrial fibrillation and sleep apnea, increasing age, male predominance. So I think there's some, shared risk factors. And although we do think about atrial fibrillation being predominantly in white individuals, there are some pockets of data showing that sleep apnea and sleep-related hypoxia in particular, which may be setting up underrepresented minorities in particular at increased risk for atrial fibrillation. So I think there's some of these nuanced characteristics, and of course, obesity being a shared risk for both.
And hypertension, I guess, yeah.
And
So
hyper.
Naomi, do you have comments about sort of value-based versus volume-based care in terms of quantity versus quality of care and how that might drive our decision-making moving forward?
Yeah, I was intrigued to hear what Anne Marie had mentioned about value-based care, and it sounded like to me that you were mentioning that value-based care is not really the answer for patients, but I would love to hear more from Anne Marie. I I mean, I see this a lot, right? We have a lot of physician burnout in my vice chair faculty affairs position. Everything is, and I'm not saying unique to Mount Sinai, this is across the board, and Mount Sinai is actually I think doing a lot to ensure that our physicians are well. But there's a demand for volume. There's an RVU productivity-based compensation for a lot of clinicians. And so I don't know if we can really not see the the volume-based part of the equation because that's what's front and center. Value-based is interesting. Even though we've talked about it, I'm not seeing a lot of it being implemented in the healthcare system. And that's often a question I'm asking when I'm sitting at the table with leadership. For example, this morning got my Press Ganey scores and, my feedback, and I see comments. And of course, we all try our best and spend as much time with our patients as we possibly can. But that comes where, with some degree of sort of a price you pay where you may not be able to see the volume that maybe others can see. And so we're not rewarding value-based care for our physicians. We don't have incentive metrics. For example, if my Press Ganey scores are high, I don't get a bonus at the end of that. And so how do we ensure that our sleep patients who are coming in with sleep disordered breathing, insomnia, restless legs, and other concomitant sleep disorders, and you have 20 minutes to see this patient, and I did a phenomenal job, for example, of spending 45 minutes because I did stuff to my schedule or whatever. I'm not seeing any money at the end of it, right?
Yeah.
And so I think to answer your question, I think we need to do more, but I would love
Yeah.
to hear more about Anne Marie's point because I think I may have either misunderstood or didn't hear her correctly.
You saw the data that Press Ganey scores correlate inversely with patient outcomes, right? So if you give people opioids and stuff, they do poorly, but patients are happy, for example. So that's good. There's a question in the chat here. The Apple Watch Series 10 was FDA approved for sleep apnea in people over 18 last September. Has anyone collected data from patients with this watch version or found it to be particularly helpful compared to alternative options? I personally don't know information about that, but maybe Rena, you want to comment on AFib detection, which is also FDA approved now?
Yeah. So I think there there's a device where right now I think it's collecting sleep data multi-night, but then has the capability eventually to collect ECG data too. I'm sorry, I'm not particularly familiar with that device that was just mentioned, the Apple device. But yeah, I think there's opportunities there for us to do better as far as not only just at a one point in time diagnostic approach, but I think in terms of understanding the disease, the burden of disease accurately, and then from a management standpoint, being able to concomitantly examine, sleep wake as it relates to burdens of AFib and how our interventions are or are not making a difference, I think is definitely an area that should be focused on. And not only AFib, but I think heart failure, volume, changes. I think there's interrelationships there as well.
Okay, great. Let's move on to talk about CPAP a little bit. So we published a meta-analysis in the Lancet Respiratory about 6 months ago now, looking at randomized studies as well as non-randomized studies. And we did observe um, improvement in cardiovascular mortality as well as all-cause mortality associated with CPAP. The result was primarily driven by the non-randomized studies, which tend to be much larger with more long-term follow-up and more outcomes, more endpoints being reached. But they're prone to healthy user effects and residual confounding. We did confounder adjustments, but those things are never perfect. And so there's some correspondence in Lancet Respiratory kind of critical of that. But where do we stand now in terms of the level of evidence for CPAP? Is there equipoise to do larger studies, or do we have definitive enough evidence already, or how do people feel about that? Maybe Naomi, you've written about this as well, about the great controversies and stuff as well. Do you want to just summarize your thoughts?
Yeah, I think this is a really obviously hot topic. And for me, it's an area of research. So we are actively investigating this. It's not an easy answer, as you know, obviously, Atul, right? So observational studies, the bulk of them demonstrated that obstructive sleep apnea is an independent risk factor for cardiovascular outcomes, including myocardial infarction, stroke, and cardiovascular death. But clinical trials, randomized clinical trials, that have looked at both primary and secondary cardiovascular disease events have not demonstrated that CPAP significantly reduced the risk of those events. And so we're now in this position where I think we have equipoise. I think the key distinguishing feature here to move forward with trials in this space is symptoms, right? And if a person is symptomatic, then randomizing them to no CPAP when we know sleep apnea, sleepiness improves with CPAP is an issue. And I would say I'm sort of sitting here in the last, and I'm actually putting a grant together on this, so I probably won't give out as much on it. But I'm not entirely sure we know how to define symptomatic patients in sleep in obstructive sleep apnea, right? So if you look at the American Academy of Sleep Medicine's definition, it's so many different things, right? You could have snoring, you could have insomnia, you could have sleepiness in the daytime, you could have gasping, pauses in breathing. I mean, if you take a patient or all your patients from a typical day, so everyone's going to have something. And so my question is that a symptomatic patient? And I just don't think so. And we're not including how many cups of caffeine that person drank before they filled out that upward score, right? They're not going to be sleepy if they're consuming a ton of caffeine, which we are currently not accounting for in our current decision models for CPAP. And so I think there's a lot that we could unfold there, but I'll stop here and see if you want to have others comment.
Naomi, one of the other things that I would say, though, is that this again shows our egocentricity, right? Where we talk about symptomatic OSA, but we are failing to recognize that OSA may be a symptom of another disorder that we're living with, right?
Great
So if
point.
I have a nervous system disease, I may be having sleep disorder breathing as a result of that. If I have epilepsy, even if that's not the main driver of sleep disorder breathing, I need to treat the sleep disorder breathing because it may be a risk mitigator for SUDEP, and it may actually yield a positive result there. And I also think that when we're talking about the treatment of obstructive sleep apnea with CPAP, I think one of the other pieces that we need to define, because the literature is starting to kind of unfold this story, is what is the timing of initiation of CPAP? Because when you're looking at the study, I looked at revascularization in acute coronary syndrome of individuals who were not previously diagnosed with OSA, and then they get diagnosed because they just had a revascularization of coronary, and they got put on CPAP. Those who were put on CPAP actually had a higher likelihood of there being increased factors for concern of further coronary disease and issues, right? And so I think that that's one time point. The second time point is, how long has the person been living with the disorder? Because when you're looking at obstructive sleep apnea, it innately is not a pulmonary issue. It really more is a neurologic issue. For some reason, the brain is not allowing for your airway to be as functional as it should be. And to the point you were talking about earlier about maintaining desaturations as long as you should. One of my personal theories around treatment emergent central apneas is that a more neurodegenerative model where the brain is like, what the heck is going on here? Well, I should stop breathing. The same as your person who has COPD. If I give them too much oxygen, I trigger them not to breathe. So I would love to hear some thoughts around that, because again, I think that it's great to use big data, but big data sometimes is missing these nuances that we're all seeing in clinic, and we don't know how to wrangle them. And so we're saying to the person who has MS or epilepsy or neuromuscular disease or whatever it might be, well, your AHI is only 7. Treatment is optional, versus the other people who might be struggling with a treatment, and perhaps it's polytherapy or others.
Yeah,
You're nodding. Go ahead.
yeah, I just this is really great discussion, and I think it just really how striking how the complexity of this is just impacting our ability to really understand things. I think what I'm hearing is that there can be overlap with sleep apnea and other sleep disorders, that there's a continuum of disease, and we're just kind of some of the data that we have are just snapshots and not really capturing the fullness of the exposures and then the symptoms. I think that this is really important. Um, yeah, so I think in terms of the continuum, that's something that I've really thought about a lot in atrial fibrillation because, we have paroxysmal and then continuous
Hmm.
and longstanding, and then there's remodeling, substrate remodeling of the heart that, and then what point is it maybe too far gone for us to really, when we intervene, we're not going to make a difference. So I think that's a really important point. And then, yes, the overlap. I mean, we have sleep apnea, but then there's insomnia. There's comorbid insomnia with sleep apnea, and then the sleepy phenotype. We know that they're in increased risk. We know that they respond better to interventions. How should that be considered? But those are the very people that maybe in a randomized control trial that we wouldn't be comfortable randomizing to control. So there's a lot of different aspects when we're now as Naomi and her group and with the workshop report that was published really just kind of lays out sort of the complexity and where we need to go from here in terms of these clinical trials and designing them.
Yeah, I think also the atypical symptoms, pediatrics as well as adults, there are lots of patients that don't have, typical sleepiness. And so we had a paper recently called The Language of Sleepiness. Some people have fatigue, some have non-restorative sleep, some are drinking a lot of coffee, some are having other things. I recently had a very close personal friend tell me never use the term mild sleep apnea ever again. And because we're talking about AHI of 7, but she had that. She was miserable. Her husband was in a different bedroom because of the snoring and whatnot. She was felt like bleep was the word she used, and uh, she got treated and it changed her life. And so she said, never use that term ever again. And it kind of hit home because it was a personal friend. And so, can we talk a little bit about that in terms of stratification by symptoms? And I'll have another part of that question, but let's just start with that in terms of symptoms and atypical symptoms and what is symptomatic or asymptomatic. Particularly kids, I think, right, Anne Marie? A lot of them don't have typical sleepiness. They have irritability or
Yeah.
hyperactivity or
Yeah, well, I mean, I think when you even just compare pediatrics to adult, right, we have a very, very significant difference in our model of diagnosing when you're talking about AHI. If you have an AHI of 1 or more, you're considered sleep apnea in pediatrics. 1 to 5 is mild, 5 to 10 is moderate, greater than 10 is severe. In the adult world, we wait until a quarter of the time that you're having disordered breathing that we're going to be like, yeah, that's something we should do. And so the reality is our bodies are not designed to necessarily be having this fragmentation, and also recognizing that as we age, we're more susceptible to only being able to continue to have this problem. And so the question becomes, if you're not going to treat obstructive sleep apnea with something like CPAP, in the pediatric world, one of the things that we've identified is things like myofunctional therapy can be very helpful. And there's been emerging data looking at this. In fact, there was just a recent systematic review looking at this in the adult world and giving a suggestion that this may be actually something that's very helpful. For me, it sounds like something that should be utilized in anyone who's being treated or not treated for obstructive sleep apnea, because it's providing rehabilitative services to your upper airway. So whether you're getting a CPAP, an oral appliance, or anything else, this is something that is going to help in better conditioning your upper airway. So I think that the challenges that we've seen, if you wanted to borrow from the studies that have been done in the past, we went from this one range where we said, okay, if it's mild sleep apnea, we don't necessarily need to treat because of the CHAT study. And then we've gone to this other end after PATS that has demonstrated that even snoring, primary snoring, has neurobehavioral consequence. And so when looking at the natural ontogeny of sleep and looking at the fact that that is a natural representation of brain health, we really need to think about what may these other consequences look like. And if it's long-standing, yes, you are not going to have reporting because I don't appreciate it as me being different. The same as the person who gains 30 pounds over the course of 3 years. That's just who they are now. They're not necessarily looking at it as something that needs to be treated right now because it's accumulating over time.
Okay. Let's talk a little bit as well about there was a recent paper in the European Heart Journal talking about sort of the CPAP risk stratification. There's a question in the chat that sort of touches on this. Oxygen desaturation index, desaturation has been reported to be a better predictor of cardiovascular risk. Do we have trials showing CPAP is better than oxygen in decreasing cardiac risk? And so Ali Azerbaijan and others have worked on the so-called sleep apnea specific hypoxic burden, looking at the area under the hypoxic curve, the magnitude, duration, frequency of desaturations. And if he adds the heart rate response, he can identify patients who do really well with CPAP in clinical trials, But then there's a group that looks to be doing slightly worse as well in clinical trials. And so people are talking about CPAP toxicity in that context, which I don't particularly believe it yet, but I need to be convinced. What do you guys think in terms of risk stratification based on symptoms or based on other physiological parameters?
Yeah, I mean, I tried to respond to that question. I accidentally did answer live, but I put the answer in there for the person who was asking. So hopefully you received it. For the head-to-head comparison between CPAP and oxygen, heartbeat is the only study I know that's looked at that from Susan Redline. Um, to answer your question, I think that's really the fundamental question we are all asking, right? Is sort of how do we assess where we're at, and then how do we move forward? And I think to Anne Marie's point, big data for me, what data science and big data has allowed me to do is to look at these questions before we move towards a clinical trial, because I think we had so many observational studies that showed what we thought we wanted to confirm in the RCTs, but unfortunately the RCTs did not show that benefit. So I would say this is a time for a pause for our field. This is a time for us to generate more data-driven hypotheses before we move into the randomized clinical trial space to confirm these. So I'm not saying the big data approach will answer them, but I think it will give us more data-driven directions that we can then explore with RCTs or the equivalent. And so to answer your question, hypoxemic burden, pulse rate response are two metrics from I would say hundreds, thousands of metrics that we have from a polysomnogram, from patient clinical characteristics, medications, alcohol use, smoking, tobacco, physical activity, diet, genetic makeup. These are two metrics. And to me, and, I love Ali's work. I think he's really helped us move this area forward. But again, I would say, do we have a full understanding of these two metrics as key surrogates for everything else that I just mentioned? And in my view, the answer is no, because I think we need a lot more work. But with that said, we can't just wait forever. So I think that's what Ali and his group is trying to do, is to say, well, do we have enough to do a smaller trial? Or what I'm doing, which is really probing into the big data, leveraging machine learning and AI to find these hidden features that may actually be more informative in a randomized trial in the future. So
Okay.
that's currently our stance, and I'll stop there.
Okay.
Yeah, if I could,
We're about halfway through, but go ahead, Rena.
oh yeah, if I could just build on that, I completely agree. I think uh, Ali and his group have done a fantastic job of moving us forward. I think, there's probably, integration of these indices. It's beyond, these two, as Naomi had mentioned, and it may be different for different outcomes, different clinical outcomes as well. And going back to heartbeat, I mean, that was, multi-center randomized controlled trial, supplemental oxygen, CPAP, healthy lifestyle, and mean arterial blood pressure was the primary outcome. So what are there other cardiovascular outcomes, or are there, the individuals in the trial, did we really include those with the most profound hypoxia that may benefit, or, loop gain, high loop gain, or, so I think there's just so many aspects. Again, agree that we need data to help better inform the way we're designing our clinical trials. And just pointing out too, we have LOFT-HF, which was terminated early, but was just the results were just published in terms of, showing that there was no benefit of nocturnal supplemental oxygen in central sleep apnea. However, again, it was terminated early. We're kind of left with not exactly knowing.
So is anybody convinced that there's a CPAP toxicity, or we need more data? We need more data. Is that
I think
fair?
we need more data. I think, the idea is that, with, hyperinflation, release of pro-inflammatory mediators, are we actually causing harm? And Naomi, you've done some work showing, right, that some groups may be more prone to deriving benefit versus others that for which there actually may be harm.
Okay, I think we need to move on, so I appreciate that part of the discussion. I would like to talk just very briefly about residual sleepiness. Oh, and by the way, there was something in Singapore just now about myofunctional therapy, a multinational study that was negative from Norway and Estonia, which it's not published yet, so that just as an aside. In terms of residual sleepiness, I saw a paper looking at non-respiratory arousals predicting sleepiness in CPAP-treated patients, which was interesting. We had a global consensus with Jorg Stier trying to get herding cats from around the world, and general consensus that about 15-20% of well-treated patients with sleep apnea on CPAP would still have some sleepiness, whether it's from non-respiratory arousals or some other reason, I don't know. But there's general consensus that we should emphasize primary therapy for the disease, but then in some patients, a wake-promoting agent like modafinil or solriamfetol may be reasonable. Emery, I know you've done a lot of work with oxybates as well as with orexin agonists and things. So can you give us your perspective from that side in terms of wake-promoting agents in the context of sleep apnea?
Sure. So I think that when looking at the utilization of wake promoting agents, just in excessive daytime sleepiness in general, we need to also think about the implications of excessive daytime sleepiness because we generally are perpetuating the stigma of that it's something to optionally treat or address. When you're talking about the thing that's going to kill you the soonest, it's not going to be the obstructive sleep apnea. It's going to be falling asleep behind the wheel and going into a motor vehicle accident. And so when we're thinking about the approach to treating sleepiness, we may want to think about, is that the primary reason that someone has come in? And whether it is early on or whether it's something persistent, one of the questions always becomes, how soon should you be treating that? Because when the person is leaving your office, being able to empower them with something to treat the sleepiness may be something that you can remove later on once they're optimally treated. When looking at the orexin agonist and even something like solriamfetol, and there have been some studies in modafinil, they are not going to just treat sleepiness. There also is going to be the impact potentially on cognition. And so when we're thinking about some of the overlaps that we get concerned about around the neurocognitive sequela of something like obstructive sleep apnea, this may also be something that is going to be able to hold you over. There is also evidence in regards to the orexin agonists that they may be something that actually treat the obstructive sleep apnea itself and may help in modifying the severity of the AHI. And so when looking at this from a more holistic perspective and also seeing what are the other symptoms that the person may be dealing with, reaching for a pharmacologic agent in combination with CPAP or whatever else you're using may be something that is going to actually allow for better quality of life, functionality, and also perhaps maybe a greater degree of persistence of use of whatever the therapy that they're utilizing.
So another orexinergic projections from the lateral hypothalamus to the hypoglossal. So they've been hoped that you might actually treat the OSA, or there was some discussion that they might lose weight because orexin has some role in appetite regulation. But I understand the clinical trials, the weight hasn't changed, which would be a nice segue to tirzepatide if we want to go there next. So, is that your understanding too, Emery, that the weight's not changing much with orexin agonists?
At this point, we're not necessarily seeing the data to support that. They haven't been reported as adverse events, which would typically be what we would identify in some of these orexin agonist studies, and especially those that have been done with narcolepsy type 1. And that may be because we're looking at selective orexin 2 agonists, and perhaps there is some need for there to be orexin 1 mediation in order to see that type of response. But I do think it's something that we'll have to kind of see what happens once we have more real world evidence related to the use of these.
All right. There was a abstract at the World Sleep meeting in Singapore just now, but people are giving the orexin agonist infusions to sleep apnea patients and kind of normalizing things, but we'll see if that's a viable approach. So since I brought up weight loss, I should mention tirzepatide, which is also known as Mounjaro or Zepbound, and I consult for Eli Lilly in full disclosure. So the SURMOUNT OSA study was published in New England Journal about a year ago, and then got FDA approved as a treatment for sleep apnea, moderate to severe sleep apnea in people with obesity last December 2024. SURMOUNT OSA had two arms, a non-CPAP arm and a CPAP arm. Both were randomized to get either tirzepatide or placebo. Primary outcome was the apnea-hypopnea index, which did improve by more than 50%. And the secondary outcomes were pre-specified and controlled for multiple comparisons, showed improvements in systolic blood pressure up to 9.5 millimeters of mercury, sleep apnea specific hypoxic burden, high sensitivity C-reactive protein, patient-reported outcomes, and 18 to 20% changes in body weight. So it was quite a big effect. It was more than I was expecting when I designed the study. But I'll shut up and listen because I'm not here to promote my own study. So what are your thoughts in terms of tirzepatide and where does it fall within the landscape of sleep apnea therapy? Naomi?
Yeah, I mean, for me personally, it's really been a great change in my practice. So we would see patients with obstructive sleep apnea and we would say CPAP. And if they didn't want CPAP, we would move to um, oral appliances. Those were sort of the two main treatment options. We, of course, have Inspire, and we have others, but some of these were surgical, and patients were obviously not very keen on upper airway intervention or, hypoglossal nerve stimulation. So one of the best things that's happened for me in my field is introduction of medications and pharmacologics, and tirzepatide has really helped because when you look at the outcomes on the SURMOUNT, it addresses a lot more than just the AHI, right? The focus was just not reducing the AHI. Patients' weight got better. They, felt better. And so I think a lot of those, when you see the practice of sleep apnea treatment, are important. We just, we didn't have anything other than the two that I was comfortable prescribing. So tirzepatide, when I now see patients, and I mentioned this as a therapy, a lot of patients who are obese and have obstructive sleep apnea are choosing to go on tirzepatide. A lot of patients are coming to us asking for that drug. And the problem, Atul, and I don't know how others are handling this, is how do you handle the demand, right? I mean, I'm a pulmonary critical care sleep medicine trained physician. I haven't prescribed drugs like tirzepatide in my practice in many years. That requires a lot of, testing, biomarkers, blood work, right? That's not our practice. That's not how we're structured. And so, how do we transition the clinical practice of sleep medicine so that we have the support staff, we have the people that we need to be able to draw labs, check labs, make the referrals. It's not set up quite yet. And so I would say we need to have discussions and help clinicians and leaders in obstructive sleep apnea programs to be able to set up something that would be functional for both the physician but also for the patient. And I'd love to hear what you've done in your practice or others. But that's currently the challenge I'm facing.
Okay. And Rena, are you looking more at sort of primary therapy? We didn't compare tirzepatide to CPAP. We compared it to placebo. So in my view, CPAP is still first-line treatment. But there are some patients who are requesting it, and how do you handle those? And then as adjunctive therapy, if they're getting some other treatment, or as a rescue therapy, if they failed some other treatment. And then some people will induce weight loss to make them eligible for alternative therapy. So where does that stand in your armamentarium right now?
That's a great question. And first of all, great. This is really phenomenal work and has really now paved the way for pharmacologics in the space of obstructive sleep apnea. Of course, we have the you know, agents for, residual excessive daytime sleepiness. So we're rounding out in terms of the role of pharmacologics in obstructive sleep apnea. Yeah, I mean, I think I don't know that I think it's a very individualized approach in terms of the patient preference and their symptom profiles and seeing which treatment would be best. Typically, starting with CPAP and it is something in different groups that I've noticed um, have kind of approached things differently in terms of whether they're taking ownership of the prescription of the tirzepatide or endocrinology colleagues who the wheels have already been greased in terms of prior authorizations and then integrating them into our colleagues endocrinology colleagues into the care pathway. So I know that it's being handled differently in different areas.
Atul, I think some of the things that are important are number one, what I think is a recurrent theme that we keep hearing here is that we need a transdisciplinary approach to acknowledging that we're treating people who have very diverse needs. And I think one of the things that is very unique in this particular situation is tirzepatide is not just a treatment for obstructive sleep apnea. It also is something that's going to treat prediabetes, diabetes, weight management, et cetera. And so one of the things that is very important to me in my practice is that I will write for the initial prescription, but every single patient who I'm writing for that initial prescription, they are doing this in lockstep with my metabolic institute. And for the reasons that were just described, of that I don't have the team to support the successful titration and adherence of that patient on that journey. And so why should I deprive them of the opportunity to be successful and safe on this medication. And so with that stated, it may also not be effective in everyone. So why should I deprive them of the relationship building and the options of other things that may help them on their weight loss journey? So I will acknowledge that I also am cardiometabolic faculty with Eli Lilly. And so we'll just make comments in regards to the study design of one of the things that I really do like about when I'm looking at this information, how I use it in my clinical practice, is when I'm looking at those who are included in with CPAP and those who are included without CPAP, it actually is interesting because it reflects very much the typical clinical patient portfolio, because it was more likely that you were on CPAP and greater than 50 years of age, and more likely that you were less than 50 and not on CPAP. And the reason I say that is because my less than 50s are like, I'm single, ready to mingle. I don't want to wear a CPAP. Where my greater than 50s are like, me and Lois, we've been married for 30 years. She doesn't care about this machine. She says it's soothing to her. And irrespective, we are seeing really substantial benefit in both of those individuals. I think that it also does introduce the concepts of that we are only having an expanding portfolio of treatments. When we look at the field of sleep medicine, which was only born in the 1970s, we didn't even have any other treatment other than tracheostomy when we first started. You had the addition of CPAP, and then you saw that there was increasing number of surgical therapies, including things like hypoglossal nerve stimulator, dental devices, and now we're seeing more and more medications really coming down the pipe. And I think that this is really just meaning that we're going to be able to treat more people more comprehensively for longer term.
Okay, cool. I will say, and not to editorialize too much, but I was guilty of this myself, that if you're a lung doctor and you're treating COPD and you don't address smoking, you're probably not a great doctor if you're not addressing the underlying cause. As I say, I was guilty of this myself. I was treating people with obesity with sleep apnea for decades with CPAP, putting a Band-Aid on the problem. And I think the data are fairly compelling that you treat both obesity and sleep apnea, not either one alone. You know, the Julio Chirino study out of Penn in New England Journal in 2014 is probably the most compelling, but I think we can say, well, we're not set up to treat obesity, but on the other hand, we probably should be, in the sense that we should be treating the underlying cause of a disease that we're addressing. And maybe that's an editorial comment, but I kind of feel like some people say, oh, we don't have the infrastructure to do this, but if you're treating COPD and you can't treat smoking cessation, you probably should get a different business, I would think.
Yeah, but I think
comment, but you can respond now. You got it.
Yeah, I think it's important to, so I think what's ideal and what's actual, right? And in the real practice of sleep medicine and the trainees that are currently at the level of providing the care, they're not trained in anything other than CPAP, to be frank, right? So to now expect them to pivot and prescribe drugs and do it right by the patient, that's the biggest point here, right? The patients need to fully understand what this is about, what are the side effects, what kind of monitoring they need, what kind of referrals they need, what's the impact on muscle mass, what kind of training, nutrition. There's a whole story to this. So I think we can't just, prescribe drugs and then leave it for either the physician or the patient to figure out. I think
I agree. So sorry to interrupt, but I think what we're emphasizing here is a multidisciplinary approach. So I'm not saying you necessarily have to prescribe it, but you need dietitians and psychologists and endocrinologists and bariatric
and training
on your team to do that. Same with if I treat insomnia, I often have a behavioral psychologist or somebody there. It doesn't mean I'm a bad doctor because I use colleagues that are more skilled than I am in certain areas.
But also it's the mass, right? The volume of patients. We're not seeing it when a new drug for insomnia comes out. When tirzepatide was approved, I mean, there were hundreds of patients. So it's also the volume. It's not just about one drug.
1 in 7 Americans has tried a GLP-1 receptor agonist as of about 6 months ago. That number is increasing, not decreasing.
Exactly.
Are you finding new barriers to prescribing? However, I'll say at my own institute, I can't even prescribe it without it having first to be vetted by one of our internal pharmacists and then deciding whether or not my clinical decision making is sufficient to be able to appropriately recognize who should be treated. And in fact, they've even tightened the barriers by saying it has to either be someone who is intellectually disabled or has already proven that they can't tolerate the use of CPAP. So just wondering if you guys have seen any other types of barriers like this.
Certainly insurance coverage and physician authorizations and financial issues and stuff come up. I will say in California, at least, we're pretty good in terms of even the undercompensated care at Medicaid, Medi-Cal, Molina. A lot of them are getting GLP-1 receptor agonists. Just a point of emphasis that tirzepatide is a GLP-1 with GIP. It's different from semaglutide, which is Ozempic or Rybelsus or Wegovy. So, Rena, you had another comment?
Yeah, I mean, I think it's kind of an example of how I think an innovation has outpaced our ability to really have everything in place in terms of infrastructure to be able to effectively administer this drug to our patients. Whereas, really, I think lends itself then for this multidisciplinary approach. But philosophically, I do agree that, this is something now that we should, as sleep specialists, get comfortable with and have developed that infrastructure to be able to allow ourselves to integrate this with, this, CPAP, kind of focused care that we've been, giving to our patients.
Okay, great. So we're talking about medications, and I think many people are familiar with Apnimed. Full disclosure, it's spun out of my former lab, but I have no equity or anything in the company. But I've done a little bit of consulting with them just on a one-off type of situation. But they have a drug called AD109, which is a drug combination of atomoxetine with oxybutynin. It's an adrenergic and cholinergic type thing. Their phase 3 results are in press releases, but the phase 3 they've not been through peer review, and I don't think we can talk about anything beyond the press releases at this point. But we can talk about Mariposa, which is the phase 2 study published in the American Journal of Respiratory Critical Care Medicine. And I just want people's thoughts on this. When you look at the intention to treat analysis in Mariposa, the AHI improvement was about 5.9 events per hour in the intention to treat. When they exclude people that had side effects and these things, they did some kind of efficacy analysis. They call it modified intention to treat, but I don't think that's actually modified intention to treat. But regardless, the effects were there and they're consistent, I think, across different studies, but relatively modest. So where do people think that stands, recognizing we'll know the phase 3 results publicly soon, and they'll be through peer review hopefully soon as well. So, Rena, do you want to start?
Yeah, I guess, I mean, again, I think this is now a different, right, mechanism of action and, beyond obesity, being able to provide a treatment and a pharmacologic treatment for sleep apnea, once considered kind of to be the holy grail of, can we find a medication that actually is going to be effective in treating obstructive sleep apnea? So I think it's very exciting. As you said, we can't discuss anything beyond what's been disclosed so far, but I think it will be interesting to know how this is tolerated for patients, the side effect profile, the folks that will most likely derive the most benefit, and understanding discontinuation rates and things like that in terms of how this kind of fits within our paradigm. But I think it's exciting.
Yeah. So one of the things that comes up though is that, when you do side effects, the average heart rate and average blood pressure go up a little bit. Usually when you look at toxicity, you're not looking for averages, you're looking for the outliers in terms of how many people are getting massive tachycardia or massive hypertension or something. I don't know that number, but that is something to keep an eye on. And the broader picture, as we alluded to earlier, was we treat sleep apnea either for symptoms, either the patients or the bed partners, or for cardiovascular risk. I mean, those are the two main reasons we're doing this. And so with heart rate and blood pressure going up, then I think symptoms will be imperative, or there are other reasons we might be doing this. So, Naomi, what are your thoughts in terms of how those medications play out? Or let's assume we don't know anything about the phase 3 other than what's in the press releases. What would you want to see in terms of cardiovascular risk or in terms of symptoms?
Yeah, I mean, I think that, this is, again, an exciting time, right? So I think this trial is significant, because it provides like the first robust evidence that a pharmacologic agent, can meaningfully reduce OSA severity in a multi-week sort of multi-night setting. And we've had other studies that have been single night or smaller samples. So I think this was very promising, but I do agree that it's not clinically approved yet for use. And what I would be looking for are obviously long-term cardiovascular outcomes or even short-term impact on blood pressure, and in more of their phase 3 data. And then maybe even comparative effectiveness studies, right? And so I think that would be sort of the next phase. But I think it's a very exciting time for our field with this potential approval, depending on the results of another drug, which works in a very different way than tirzepatide, and maybe for a group of patients that may have milder disease severity of sleep apnea, and maybe in patients where we're not worried about blood pressure or heart rate because of the fact that they're athletes or I don't know, right? And they may still have sleep apnea. So I think again, this just gives us more to work with, and I'm really excited for the field.
Yeah, so Naomi, are you looking for, is the improvement in AHI enough for you in terms of an outcome, or are you looking for symptoms or cardiovascular risk or something? Because we'll have to see.
Yeah, I mean, obviously, currently the metric we are all used to is AHI. So we can't, until we have something that we can replace it with, I would be looking for that because that's a marker of the disease. And then we can compare it with other drugs like tirzepatide or what CPAP would do. So I think, yes, absolutely, that's a number I am looking for. And in their trials, it's been about a 50% reduction or slightly less than that in the Mariposa study. And so cardiovascular, I mean, blood pressure is a good marker. I think heart rate is.
Mariposa, the AHI change was 5.9 events in the intention to treat, not in the modified thing. So
Yeah. But about from where they started baseline, right? I don't know. Maybe I'm not recalling, but I thought it was like a 40+% reduction, percent, not the absolute numbers.
yeah, but if you're treating a patient in front of you, is the AHI change the way you'll sell it to
Yeah.
them, or is it that's enough for you?
Yeah, and so, actually, I've been seeing a lot of this in my practice. I actually just last week saw two patients who went from 12 to 6. And this is a therapy that I am using that we haven't talked about called Excite OSA. I don't know if you guys are familiar with it. And, patients actually feel a lot better. So this is a very mild OSA patient group that, just didn't want CPAP, not obese, and 6 or 7 AHI, which would be about a 40% reduction. And there is clinically meaningful improvement in these obviously small sample size of patients I'm discussing. But, this is what I am excited about with my field at the moment, that I have these tools. I can sort of figure out which one works best for my patients. And so the more I can work with, the better it is. But I think we will need a multidisciplinary approach to ensure we have all of the right resources available as physicians.
Yeah,
So
full disclosure. Full disclosure. I ran some of the studies for Excito. Say I have a friendship with their CEO. I don't take money from the company, but Anne-Marie, go ahead.
So, Atul, I want to put it back on you. What is your approach? What is the patient profile for when you're looking at the spectrum of therapies? You have your hypoglossal nerve stimulators, you have your PAP therapies, you now have medications, you have oral appliances. I know that one of my most favorite quotes from you is in regards to one of the talks that you gave about preferred therapies. And so, how do you approach this? How do you identify with your patient what is the best approach? And then when do you pull the trigger on saying, this is clearly is not working? um, Either layering in another therapy or changing the therapy altogether.
Yeah, so I'm not here to answer questions. So I'm here to to ask them. So that's a longer conversation we have time for. But I do want to talk about hypoglossal nerve stimulation. What I will say as part of shared decision making is having the conversation about this. And I'll push back a little bit on Naomi saying most of my patients don't give a bleep what their AHI is doing. And I often say with Surmount OSA, we cut the AHI by 55, 60%, but in isolation, I don't care. That's just a number. There were surgeons that operate on people trying to make the AHI go from 80 to 40 with a UPPP, and we all said that that's not good enough. They still need CPAP. So I think part of shared decision making is what matters to you, and it's usually symptoms or cardiovascular risk. Some are concerned about cancer risk or Alzheimer's risk, but we don't really have definitive data in that context. But let's talk about hypoglossal nerve.
Sorry, can I just clarify my point? I think you're absolutely right. That is the goal. What I was mentioning is that I was surprised that when their AHI dropped by 4 to 5 points, they were feeling so much better. And so I think this just describes the discrepancy we have between how well or how poorly AHI correlates with symptom and how much AHI reduction you need for symptomatic improvement. So I agree with you, Atul. I think we're saying the same thing. I was just surprised to see how much they improve symptomatically with a small reduction in AHI. So that was my point.
Yeah, there's some debate with tirzepatide how big the patient-reported outcome improvements were, the PROMIS scales and things. So Sanjay Patel, our mutual friend, wrote the editorial in New England Journal about that, and I gave him a hard time about it because we started arguing about it, like what is a clinically important difference in the PROMIS scales. But I often say those in a tirzepatide study, if somebody's losing 20% of their body weight, going from 200 pounds to 160 pounds, 40-pound weight loss, you can't blind a study like that. It's obvious who's in which group, and so these subjective things become a bit bogus. With concomitant changes in objective and subjective outcomes, I take it much more seriously. And so the fact that we didn't just make the numbers look better, but the patients felt better, I think to me was quite compelling. The other part of it that Anne Marie and I, when we first met in Brazil a couple of years ago, and hit it off as respected colleagues, one of the things I always say is, I used to say that CPAP is the treatment of choice. I got called on it by somebody saying, "Is that your choice or the patient's choice?" I was like, "What do you mean? It's the treatment of choice." It's like a medical term. I was like, "Well, whose choice?" And it was a good time for introspection for me, saying that, these are shared decision-making things. And so I now say it's first-line treatment to use CPAP, but I don't say it's treatment choice necessarily unless the patient's on the same
Yeah,
page.
and just I know we're want to move to another topic, but I think this also made me reflect on the number of times I was seeing patients where I was prescribing a CPAP and their AHI went from like 45 to 2, right? But the patient was telling me, I don't feel like I'm sleeping that much better, or I'm still tired, or I wake up so many times because I hate the mask, right? And so it just makes me realize, I think to all of the points we're making is that we have to listen to our patient. That's the bottom line. If the patient is not feeling better with the therapy, the AHI reduction to me is clearly not carrying as much
Yeah.
weight. That time I didn't have options. I didn't have
So,
the other options I have today. So I think this is a great discussion on that
so I
point.
think I think you're now agreeing with me that with any pharmacological therapy, you want to see either improvements in cardiovascular risk or symptoms, right? It's not changing a number. And I
Yeah.
think to quote a cliche, we're not treating a number, we're treating a patient, and if it's just the AHI changing or just the some other number changing in isolation, that's sort of meaningless, I think. So let's talk about hypoglossal nerve stimulation. And full disclosure, I was the global PI for the LivaNova Osprey study, which there's press releases on, but I'm not allowed to say more than that, other than the press releases showed we met our primary outcomes. It's a randomized controlled trial. The Nixo device just got FDA approved recently, which is this midline incision with subplatysma stimulation. And the Inspire device got FDA approved. It was my daughter's birthday. It was April 30th, 2014. So I remember the date. Based on New England Journal paper in 2014. It was a case series where they gave people hypoglossal nerve stimulation and then did a randomized withdrawal among the responders. But now a 5-year follow-up on that looks pretty compelling. Over 100,000 patients implanted now, 11 years later. I know there's a pediatric angle as well in Down syndrome and whatnot that Anne Marie would be very familiar with. Where does that stand in our armamentarium in terms of, I used to say the best surgery for sleep apnea is bariatric. I no longer say that, in part because I think tirzepatide's probably, if I had a choice, I'd take that over bariatric surgery. But secondly, the data for hypoglossal nerve stimulation are becoming more compelling. So what are people's thoughts on where that stands in the armamentarium?
I would say that one of the things that may potentially influence reaching for that is where you are from a location perspective. And do you have a surgeon who is equipped to do it? Do you have a lab that is equipped to do the titrations? From a pediatric perspective with children who have Down syndrome, it really is for our center a highly selective process because we want to make sure that the child has the intellectual capacity to be able to manage that, make sure that they don't have any sensory integration issues that would make it more challenging for them. And then also looking at what is their other medical comorbidity. Do they have significant cardiac disease where we really don't want to put them under for another surgery or complicate things? So I would say that has been a rate limiting step. On the other end of it, though, our adult program is quite robust. We tend to make sure that we have a focused group who primarily are managing those individuals who have Inspire rather than just having everyone do kind of the one off. So that this way it really is, as we were talking about tirzepatide, the same concept of really centralizing resources so you have the greatest degree of expertise and the highest throughput, and also the ability by having that centralized pathway to recognize where there are opportunities to either refine who should be getting it or the consideration for it, and being able to do kind of those little nuances that tend to be reflective of the quote unquote art of medicine.
Okay, Rita, you're had some very prominent papers from the ADHERE registry with the hypoglossal nerve stimulation. And if I could summarize what I recall, at least, it's the older patients seem to do better, women seem to do better, the lower BMIs, I think, do better. Are those findings, are they standing the test of time, and does that change your management in terms of what you're looking for?
Yeah, I mean, I think, yeah, I agree with what Aunt Emery just said in terms of what I'm learning in terms of location. At the Cleveland Clinic, there was a center of excellence where there was a process and an inter and multidisciplinary approach with the implantation of the device. And University of Washington, it's a bit different in terms of the philosophical approach. So it's really interesting to see the site differences. And you're right. I mean, and the findings, especially with women, I feel like are notable. I mean, it was like a threefold increased odds of responsivity for women versus men. I mean, it was a strong magnitude there. Um, and in the landscape where women are less likely to be approved for these devices. So I think that is something that, at least in my practice, I really try to make sure it rises to the level of conversation with my women, especially with moderate to severe sleep apnea who otherwise meet criteria.
So,
Rena,
Rita,
can I just ask a clarifying question? In the women, is it tend to be more postmenopausal women?
Yeah, I mean, I cannot remember the age in particular, the average age of the cohort, so I'd have
Yeah,
to go back and look. But yeah, I do believe it was more middle-aged. I don't know if they were postmenopausal. We still don't know the exact, mechanism by which this
yeah,
was occurring. But and when I say responsivity, it was reduction of AHI. So, symptom profiles, I think that's maybe a little bit less clear. But
sure.
yeah, I think it's really these pockets of data I feel like we have to pay attention to, and I'm happy to see that the American Academy of Sleep Medicine has assembled a task force to more closely look at, sex-specific differences in sleep apnea in terms of diagnostics, management, interventions. I think this is a really important area.
in general, older did better than younger in the ADHERE registry too. So I think postmenopausal probably is what's overrepresented there. Just to dive a little bit deeper and putting my physiology hat on for a second because I can't help it, is men are different from women with sleep apnea, perhaps because their control of breathing is different, their lip gain and whatnot. Or it could be there's a selection bias, like the men tend to be more in the VA systems and have comorbidities like COPD or PTSD or whatever else is there. So,
Hmm.
do you think it's sort of biological differences between men and women with sleep apnea, or do you think it's um, logistic differences between the VA and non-VA, those kinds of things? Because I think reimbursement through the VA is pretty good, and those tend to be more complex patients, at least in my experience.
Well, the reason I was asking a question of whether you're postmenopausal is because you're going to have increased collapsibility with the drops in estrogens and progesterones, which are going to make you having a floppy airway. So it would make more sense that if I have electrophysiologic stimulation of the upper airway compensating for that change, that you may see a much more robust profile than if it's related to other factors that may be driving obstructive sleep apnea. But I would anticipate in real world, it's probably a combination.
Yeah, agreed. So, Rita, do you have a sense, or do you want to take? I don't think we know, so you can say whatever you want. But do you think the difference are physiological differences or sort of logistic differences between men and women?
You're right. I mean, it's really hard to say, but we do know that there are sex-specific differences in arousal responses to respiratory events and other aspects, and even ventilatory responses between men and women, hypoxic ventilatory responses, even as it relates to different sleep stages. So I think, there are um, probably endotypic, right? Physiologic differences. It's hard to tell, which could be, or are there structural, systemic sort of reasons as you're alluding to? It's maybe a combination of both.
Okay. There's a question in the chat which is interesting. It says a little confusing. We say focus on symptoms and not on the HI reduction, yet the cardiovascular risk and the way we know it correlates with hypoxic index and O2 saturation. So is it hypoxia or is it symptoms or both? I think it's a good question. It's a hard one to answer. I think in the Ali Azerbaijan European Heart Journal thing, it was hypoxic burden and heart rate response were the predictors of who had major benefits to CPAP versus those that didn't. On the other hand, I think many of us believe that the symptomatic sleep apnea patients are the ones who get the biggest bang for the buck as well. So recognizing the word symptomatic is also hard to define. So what are your guys' thoughts there in terms of, is it symptoms or hypoxia or both? Obvious answer is both, but let's dive in a bit deeper.
Yeah, I think this is oh, Anne-Marie, did you want to comment?
No.
Oh yeah, I think this is exactly what we were discussing earlier, right? Is it the hypoxemic burden and what is hypoxemic burden surrogate for potentially, and also what are symptoms, right? What's a symptomatic OSA patient? I'm not entirely sure. Is someone who snores a symptomatic OSA patient, and are they at high risk for cardiovascular events? Is someone who is sleepy on an Epworth sleepiness score, which some of the questions don't apply to an urban population that doesn't drive, for example, in New York City. These are all great questions, and I think this is a fabulous time, and this is why I love sleep research, is because there are so many unanswered questions, and we just need a lot of people, and the pipeline just can continue to grow to be able to answer these. But I don't think we have the answers, and hence it's confusing because we don't have definitions for what symptoms are, what sleep apnea is. It is AHI or all the other stuff we've talked about, and also cardiovascular risk, right? We mentioned hypertension. Do we want hard cardiovascular outcomes? Are we looking at some of the, sort of intermediate or non-event type endpoints? And I think all of these are great questions. We just don't have all the answers. So
one thing I used to say, which might be different now, is I used to say, well, the symptomatic ones are perhaps the ones at highest risk, but they're also the easiest to treat because of CPAP. Now that we have alternative therapies like tirzepatide or hypoglossal nerve stimulation, focusing on symptomatic patients to treat them may not be necessary. So if you have massive hypoxia without symptoms, maybe those are patients who are amenable to intervention because we don't have to have them adherent to CPAP anymore. All right, so we have about 5 minutes left, and so I'm gonna put something on the table, and that is the future. And I'll make 3 statements, and I'll let you guys agree or disagree with all 3 of them. So I'll say the future of this is kind of endophenotyping. Not all sleep apnea is the same. People get sleep apnea for different mechanisms, and they vary in their clinical expression. Some are at cardiovascular risk, some are not. Diego Mazzotti's data said the most symptomatic cluster were the group that had cardiovascular risk and sleep heart health, but that's what we're actively debating. Risk stratification may be helpful, whether Ali Azerbaijan's a technique with hypoxic burden and heart rate response is the way to go, or maybe biomarkers with microRNAs, or with machine learning techniques, or with exosomes, or there's other ways of risk stratification, but I think that could be important. And then sort of tailored therapy, individualizing therapy, personalizing therapy, this kind of thing. So the 3 components of the future, I think, will be endophenotyping, understanding variability. 2 is risk stratification. 3 is tailored, individualized, personalized therapy with shared decision-making. Does anybody agree or disagree? We have about 1 minute each, so Anne-Marie, you go first.
I would just layer in, I agree, but I would also look at the longitudinal changes of the endophenotyping, because looking at the child who has obstructive sleep apnea, gets intervention, redevelops it, that's going to be a different endophenotype than someone who develops obstructive sleep apnea without that history.
So they're moving targets, the mechanisms and the clinical expression. And I see that as well. We had a paper out of Israel with Peretz Levi and stuff some years ago where there was some progression over time. The DSATs got worse. Probably the arousal threshold was changing over time. Some of them gain weight over time as well and become symptomatic. So things can change. It's a good point. Rena, go ahead. What are your thoughts in terms of endophenotyping, risk stratification, and tailored, personalized, individualized therapy?
I think you summarized it extremely well. And notwithstanding the existential questions that remain unanswered, as has been pointed out, I think, I think this is the direction we need to be thinking about, like, what is the root cause of the pathophysiology? How do we tailor our interventions appropriately? How do we maximize all of the rich data that we're collecting to help us answer key questions that remain unanswered? The longitudinal trajectories, I think it's really important. We are lacking any longitudinal, large cohort studies that over time really characterize in detail what's going on with the physiology, how that relates to outcomes, and also the environmental sociocultural aspects and influences on sleep and circadian rhythm disruption. So I think our field is lacking that. We try to latch onto other cohorts to answer some of these questions, but there's no kind of dedicated sleep cohort, and so that comes to mind as well.
Okay, Naomi, do you have anything to add or subtract?
Yeah, and in sort of the traditional way that I do this, I'm going to leave with a provocative question, right? And I think this is really what has made me want to sort of research this and go into the field for sleep apnea. And I think that we've talked a lot about prevalence, right? But prevalence it doesn't necessarily mean disease, right? We have something that's prevalent, which is a high AHI, but disease to me means consequences, right? And what are the consequences that we definitively as a group can say can be uniquely attributed to OSA and OSA alone? Meaning not sleep deficiency, not circadian misalignment, not other cardiometabolic disease states, obesity. And to me, until we answer that question, everything that you proposed is a question mark in my mind. And so that's where I'm at. How I'm approaching the field is really, is it a disease? And if so, what are the consequences that our patients or sort of human health encounters that's uniquely attributed to OSA?
Okay, great. I think we have about 1 minute left, so let me just try and summarize it. First of all, I want to say thank you to these three are personal friends of mine, as may have come across during the discussions. Thank you. I refer to them by first name because we're good friends. So thank you, Naomi. Thank you, Rena. Thank you, Anne Marie. Also, thanks to Christine Davis and to Phil for helping organize this, and thanks to the Sleep Research Society Foundation for making this happen. Also, thanks again to the corporate sponsors who helped guide us in terms of support for this initiative. I learned a lot from this conversation. There is a durable material that comes out of this as a thing. So if you enjoyed today, please give us your feedback, but also recommend to others to go ahead and watch the video online. And if you don't like my sense of humor, then don't recommend it. Otherwise, I definitely would recommend this as a follow-up. So I enjoyed this a lot. Hopefully we'll be invited back and we can address other questions. Certainly if there's other feedback, please email me privately. I'm happy to take criticism. So thank you all for participating. And as I say, I enjoyed this.
Thank you, Atul,
Thank
for
you.
moderating.
Yes, thanks.
Thank you.